It's usually not a problem. So anyways, so what we're going to discuss is scleroderma-associated pulmonary hypertension. I'm a respirologist, so it may seem funny, why am I talking about a heart disease? Wouldn't that be a cardiologist? And I think one of the key things that you need to think about is that this is a disease that's related to high blood pressure in the lungs, rather than high blood pressure necessarily in the heart. The heart is sort of the innocent bystander that gets affected by this increased pressure, which we'll discuss. So, sort of the objectives of what we're going to go through. I think it's a little bit of a full list of objectives here, but certainly we'll focus on a few of them in particular. So first question is, what is pulmonary hypertension? And I'll be referring to pulmonary hypertension as PAH, sort of interchangeably throughout the talk. We're going to outline the characteristic symptoms, so these are what you experience when you have pulmonary hypertension. And certainly also, and this was sort of alluded to in the earlier discussions, is how is the diagnosis of pulmonary hypertension made and what tests are involved. We're also going to discuss whether or not screening is effective. And that was certainly a question that was brought up earlier in terms of how often should we be screened for pulmonary hypertension if you have been previously diagnosed with scleroderma. And briefly, we're going to outline the available treatment options. So I thought it would be useful to start with a case because this sort of puts everything into perspective. This is a case of a 55-year-old gentleman who worked in heating and cooling. And he described an 18-month history of progressive breathlessness. So 18 months seems like a long time, but in an individual patient that is actually sort of a blip in the radar. You attribute that breathlessness to a whole slew of other factors. Well, you know what, I'm not working out or exercising as much as I used to. Well, over holidays I put on about a good 10 pounds, and that's the reason why I feel breathless. So people often attribute their symptoms to other more benign causes, and that's sort of, I think everyone does that. This patient himself, he was a lifelong non-smoker, and as a result of his progressive breathlessness, he wasn't able to walk up a flight of stairs any longer. In terms of going for groceries was incredibly difficult. In terms of bathing or dressing without difficulty was next to impossible for him. And as a result of his progressive disease, he was forced into early retirement at age 55 without an extended pension. This was a major issue for him in terms of his overall life and supporting his family. This would not be unfamiliar territory for many of the audience members, but certainly one of the big things that when we were asking him about in terms of his other symptoms was that he had a long-standing history of Raynaud's symptoms, which were discussed earlier, as well as extensive telangiectasias. And telangiectasias are those little red dots that you often have on your fingertips and as well on your face. He also described that he was having these periodic episodes of fainting, and we call this syncope. So he would often, whenever he was exercising, he would just pass out entirely. And certainly that was concerning. And what was also concerning is that he was starting to put on a lot of weight. And earlier we discussed the issues associated with weight loss, which can be a very concerning finding. But certainly weight gain is equally concerning because in this setting it's related to fluid retention, and that he was retaining a lot of fluid, and as a result of that he was gaining weight. And as a result of the skin tightening that classically accompanies scleroderma, it's not uncommon that you're often very good at hiding fluid because it doesn't manifest in sort of the same way. You don't get the really puffy legs or anything like that. It's much more difficult to pick up sometimes. So, what is pulmonary hypertension? So everyone's been to the family doctor and they obviously measure your blood pressure. Usually, and what they're measuring is the pressure on the left side of your heart. So in normal persons, that's usually about 120 on 80. It seems that everyone over the age of 50 typically begins to develop pressures with high blood pressure, and certainly that you can see numbers of 150 on 90, 190 on 100, these sort of pressures on the left side. Pulmonary hypertension in contrast, is related to high blood pressure on the right side of the heart. And in the normal circumstance, the pressure on the right side of the heart is 20 on 5. So compare 20 on 5 to 120 on 80. Those are entirely different. And the way that those two sides of the heart, the right side of the heart and the left side of the heart function is actually quite different in terms of where they also pump blood. So the left side of the heart pumps blood to your muscles. It pumps blood to your brain. It pumps blood to your kidneys, your liver, your intestine. It basically pumps it everywhere. The one place it doesn't pump blood is your lungs. And that's the job of the right heart. Is it basically takes oxygen-poor blood from your veins and pumps it all to the lungs so it picks up oxygen, returns it back to the left side, which then pumps it to the rest of the body. So if anyone's in plumbing, it's basically two different circuits that are in series with one another. Okay. And what happens with pulmonary hypertension, I think Andrea's description a little bit earlier is spot on, is that this is a disease of the small blood vessels that go out into the lungs. They're actually within the lungs themselves. And what happens is that in the left panel there, you can see that that's a normal type anatomy. And on the right is someone who has pulmonary hypertension. And what you see is you get a progressive narrowing of that actual vessel. And it's that narrowing of the vessel which certainly impedes blood flow. And that increases the amount of resistance and the amount of stress. And you can imagine that if you needed to pump the same amount of volume through that tiny hole as you did the big hole, then what would have to happen there is you'd need to increase the amount of pressure and force to actually generate the same amount of blood flow. And it's that increase in flow, or that increase in pressure that is pulmonary hypertension. As a result of this progressive remodeling or abnormal architecture that you see of your actual pulmonary vessels, what you end up losing a lot of the actual vessels on the periphery of the lung. And as a result of that, you get short of breath. Because certainly you're not moving as much blood to the different areas of the lungs. Does that make sense? Yeah. Perfect. So, what's the association between scleroderma or systemic sclerosis and pulmonary hypertension? Well, pulmonary hypertension probably, if you look at numerous large registries, these are big data sets of patients with scleroderma, affects about 10 to 12% of patients who do have scleroderma. If you look at a group of patients who have pulmonary hypertension, what you'll find is that between 25 and 40% of them have scleroderma. So in terms of our clinic that Andrea and I work in the pulmonary hypertension clinic, we see a large proportion of our patients have scleroderma, either in their very early stages or sometimes a more advanced disease. And certainly the importance of pulmonary hypertension in patients who have scleroderma is critical, as it certainly is associated with a worse or impaired quality of life related to breathlessness, reduced functional capacity in terms of complex activities or even simple activities of daily life, and certainly has important survival implications as well. So, what are the cardinal symptoms that everyone should be alerted to that should alert you to the presence of pulmonary hypertension? Well, it's sort of the problem with pulmonary hypertension is that the leading symptom is exertional breathlessness, or shortness of breath when you exert yourself, which, as I said to you earlier, you can attribute to many other different causes. Anemia, for instance, that was discussed earlier, can certainly cause you to be short of breath. Having some renal impairment and fluid or kidney impairment and fluid retention can cause you to be short of breath. So in itself is not that specific. With more progressive disease or worsening disease, you start to get chest pain. That's very similar to someone who's having a heart attack in terms of that chest heaviness can occur. You can have these fainting spells, which are certainly suggestive of more advanced disease. Leg swelling and fluid retention generally only occur when the disease is getting progressively worse in terms of more of the more advanced stages. And what's concerning is that certainly physical examination is critical when evaluating patients for pulmonary hypertension, but there are not very many physical exam findings where you can say, or there's none, where if it's not there, you can rule out pulmonary hypertension. So just because your legs aren't swollen doesn't mean you don't have pulmonary hypertension. Just because you don't hear a murmur over the heart doesn't mean you don't have pulmonary hypertension. And so because of that, you need to have a very high clinical level of suspicion in every patient who has scleroderma who is describing breathlessness that this may be something that's going on. So, how do we get the diagnosis? Well, as many of my patients will sort of attest to, is I order a lot of tests. And I apologize, because I know it's inconvenient and some of the tests aren't necessarily pleasant. But it's important because there are numerous different causes of pulmonary hypertension, including many different causes of pulmonary hypertension in patients who have scleroderma. For instance, if you have significant interstitial lung disease, that can cause pulmonary hypertension. Obviously, if you throw in blood clots before associated with a scleroderma, that can cause pulmonary hypertension. We also know that patients with scleroderma have problems with the left side of the heart, so that may also be involved. So we need to really figure out why each patient has a contribution of pulmonary hypertension to their disease. This includes an extended blood work panel that was discussed earlier, an electrocardiogram or an ECG which is just the electrode readings that you have on your chest. Pulmonary function testing, that's when you go into the body box. It's the clear, transparent box, and you do this series of breathing exercises, and someone's yelling at you the entire time to breathe harder, breathe harder, breathe harder. And you're like, what is wrong with you? Like, how is this part of the protocol? It's amazing. Prompted breathing tests, people always blow about a good 200 milliliters further than otherwise. So you get the best test when someone's screaming in your ear. I think it maybe just to deter them from doing it. Please stop, I'll do what you say. Anyways. A CAT scan or a CT chest is something that we order in almost all of our patients. Nuclear scans of the lung. But the two basic primary tests that we're using are the echocardiogram. That's the ultrasound. You go in, someone's pressing hard with a probe over your chest, and you hear the and you're just like, that sounds weird. And you ask them about, well, what does it show? And they don't tell you anything. And that's sort of the way that works. And then the right heart catheterization is something that we reserve for a very small proportion of patients who we really think have the actual pulmonary hypertension. This is not a screening test. This is something patients who we want to diagnose it formally, and we'll talk about that. So this is an echocardiogram. On the left panel is someone who has pulmonary hypertension, and on the right panel is someone who is normal. And what you can see is that they almost look like mirror images of one another. You can see that, actually I'm going to come up to the, so people can see. So this here is a normal right ventricle. You can see that it's much smaller than the normal left ventricle, and that the septum, which is the wall that separates the two, is sort of bowed to the right. In pulmonary hypertension, it's the exact opposite. The right ventricle is bigger than the left ventricle, and the wall that separates them is actually bowed to the left. And this actually results in problems with both the right ventricle and the left ventricle because this is such a wayward axis of the heart. You can also see that the filling chambers of the heart are also enlarged. So this is a right heart catheterization. And the reason why this is required for patients with pulmonary hypertension is that an echocardiogram is a screening test. It is not a diagnostic test. There are multiple areas of variability and error with the test. And as a result, if we really want to confirm the diagnosis, a right heart catheterization is necessary. In this test, here in Hamilton, it happens at the Hamilton General Hospital. A catheter is thread either through your neck or your groin, and it's the interventional cardiologists who do this for a living are the ones who are doing it. And this catheter is thread up into the heart where you can actually measure the pressures that are in the heart, and it also tells you how well the heart is functioning. So it gives us important both diagnostic and prognostic variables that are important in terms of predicting treatment. So, is there a way that you can predict who needs to go ahead with echocardiogram, who needs to proceed with a right heart catheterization? So this was actually studied in the DETECT trial. And this was basically a very large screening trial in a group of patients who had scleroderma, specifically looking at pulmonary hypertension. And coming up with, through this this algorithm of multiple variables that some people would argue aren't necessarily readily available for everyone, but it's a fairly simplified calculator. You can sort of predict someone's risk of developing pulmonary hypertension with scleroderma, and then determining their need to proceed with more invasive strategies. My approach to screening in pulmonary hypertension is that annually patients should have a pulmonary function test done, and they should also have an echocardiogram done annually. I think you can certainly use the calculator to figure out exactly which patient you should be screened with echo. I think that can get complicated, particularly in more of a resource-strained environment. But I think a very safe bet across the board, unless you're specifically using this criteria, is that everyone should have an echocardiogram once a year. So, treatment. Prior to 1995, there were no effective treatments for the treatment of pulmonary hypertension in the setting of scleroderma. Since 1995, there's really been an explosion of treatments that are now available. This sort of, initially it was very invasive, intravenous and continuous subcutaneous infusions. Obviously this is not very pleasant to have this, but now we have multiple oral therapies that are available for the treatment of pulmonary hypertension, including the Viagra and Cialis that were mentioned previously. So certainly that was sort of one loophole that we can manage our patients who have really bad Raynaud's with these drugs, is if they also have pulmonary hypertension, which Health Canada has approved the use of these medications for that indication. What you can see now is that we have 10 different drugs that are available, and you can use these drugs in combination as aggressive as we can to treat patients who have pulmonary hypertension in the setting of scleroderma. So, does treatment improve that long-term outcome? The answer is unequivocally yes. What you can see in the blue curve there is the expected survival of patients with pulmonary hypertension prior to the advent of therapies specific for the disease. And what you can see is that the 50% survival, so in terms of 50% of patients, only 50% of patients were still alive at 2 years. So certainly that is a terrible prognosis that's on par with some of the worst cancers that we have, whether you're talking about lung cancer, pancreatic cancer, or idiopathic pulmonary fibrosis. What you can see is that with the advent of therapies, the curve has changed dramatically. The brown curve you see there is with the availability of IV therapies, and the red curve is the most recent projection of survival for those patients since the advent of both oral and IV therapies that are available here in Canada. So certainly, this has really transformed the disease, its management, and its long-term course. In terms of an approach to treatment, I think certainly we like to follow a stepwise sort of algorithmic approach to treatment. First and foremost, education and support, as well as exercise rehabilitation are critical for our patients, whether that be through pulmonary rehabilitation or working through a physiotherapist or something else on your own time. Pregnancy counseling is critical for our young patients. Salt-restricted diets and diuretics are required if fluid retention is a problem, as well as oxygen therapy if someone's oxygen levels drop, and the 6-minute walk test was mentioned previously, and certainly that's a test that we order regularly in our patients. In terms of therapy, our first step is really to treat patients with oral therapies, unless they come in with really, really severe disease, in which case we'll go right to the more invasive treatments. But if symptoms are only mild and the right heart cath shows it isn't that bad, what we end up doing is monotherapy with the drugs, or starting right up front with 2 oral drugs. And for those patients who have very severe disease, certainly starting with IV or subcutaneous infusions, which obviously are more invasive, or lung transplantation are considerations. So, in our patient, we diagnosed him with severe scleroderma-related pulmonary hypertension, and as a result of the severity of his disease, he was started on a continuous IV therapy. And you can sort of see there, this is called a Hickman line that he had inserted over his right chest. It's a tunnel catheter, so they sort of tunnel through your fat tissue on your chest, and then it drops right into your blood vessels. And it administers the drug right next to the heart. And so it works out dramatic improvement in symptoms as a result of this invasive therapy, but now you have this line. Certainly this would not be our first line therapy for everyone. The majority of patients are treated with oral therapies. And as you can imagine, this is an additional burden not only on him, but his family. In terms of his family have to become aware as to how to mix up these drugs, how to run the pump that sits on his waist. There's a lot of other things involved, so it's a very intensive arrangement, and certainly everyone needs to be on board. And without the help of Andrea and the other people part of our PAH team, including our pharmacy team, this would not be possible. And certainly the patient was also referred to lung transplant, but given his dramatic clinical response, he didn't need it. So certainly we're keeping a close eye on him, but he's responded beautifully, and he's almost ready to go back to work now, so that's been a dramatic improvement for him. So, take-home messages. So, exertional breathlessness or shortness of breath when you exert yourself should not be ignored. Annual screening is recommended, and this is usually in the form of an echocardiogram. Early diagnosis does make a difference, as if we are able to diagnose this disease early, we can initiate treatment early, and certainly that has improved outcome in terms of long-term survival. Accurate diagnosis has important treatment and prognostic implications, and certainly I think we discussed a few of the different, the evolving treatment landscape for patients with this disease. So, thank you.